Recording in progress.
Can you see? Oh, I need to sign up again.
Yeah, you need to your joiners too.
Yeah. Where is the other one? Trying to see where is the other one.
Go to mute, Manav.
Yeah, I'm trying to figure out which of the
Hey guys, we'll be starting shortly. Sorry for that noise. There is some sharing issue. So give us another minute. Anyhow, we have 1 minute before we start. So give us some time. Any luck with sharing? I've muted you, so your this version is also muted right now. Okay, I'll unmute you.
If not, I'll just, I'm at my friend's place. I'll just log in from her computer. If it's only thing will be I'll have to share my. Let's share my screen. I have no idea why it's not letting me share my screen. This is crazy.
That's very odd. I don't know. Guys, just some issue with sharing of the screen. Let's wait for another minute and she's logging in from a different system and we'll be starting after that. So be with us for another minute and we'll start soon. Yeah. Try and log in now.
Can you
And share your screen.
yeah, let's see now. It's not letting me share my screen. I don't know why it's doing this.
Not now also.
It's telling me I've given all the permissions to for it to share it also. It's still, let me just do this one thing.
What is the error which is coming on screen?
That error, it's telling me that I have to give permission for it to be seen, and I'm giving it all the permissions, but it's not sharing it. Every time it's giving me the repeat, I'm putting in the password and giving it access to share the screen, but it keeps telling me that give it again. So I don't know why it's doing that. I think it's detecting something which it doesn't like.
Did you try to use another laptop? You were saying now.
That's my friend's. I don't know, but the only problem is all my stuff is all downloaded here. Then I have to transfer it to. I'll have to put it on my jump drive or something like that and open it and give it something like that. Let's see.
Okay.
Let's see. Give me 1 second. Let me just put this one more time. Let me see if I can join from the browser again and see if it help. It's going to let me.
No, but there is some setting issues. I don't think that will sort it out. So you will need to just give the permission in the settings only. Is something.
Yeah, I've tried that only. It's not letting me. It's not accepting it. It's taking my password, but it's giving me the same message again.
Okay. In system settings.
Yeah, give me 1 second. Let me go again now. Okay, system settings.
I'm also going along with you so that I can check. So you go to accessibility.
Accessibility, okay. Mm-hmm. Zoom.
Yeah, do you see Zoom?
Yeah.
Okay, not. Let me just check out if I can find out the right setting. Give me a minute.
Let me see if I can get Shweta's laptop. Give me 1 second.
So go to system settings, go to general.
General, okay, give me 1 second.
I'm reading and doing it along with you. Go to system settings.
General.
Go to sharing. In general, there is a sharing. And you need
click on file sharing and media sharing.
Yes, probably activate that.
Okay, let me just put the password. Okay. Media sharing, screen sharing. Okay, so I should just do screen sharing, right?
Right, only screen sharing, right? And also go to privacy and security.
Privacy and security. Give me 1 second. Yeah.
There would be an option of screen and system audio recording.
Screen and system.
Almost at the bottom.
Okay, let's see. Yep, correct.
Go there and give permission to Zoom.
I don't know. It's like I don't see Zoom in that thing. There's just Google Chrome. Even though I have Zoom over here, it's not letting me.
So do you see? I see an option of Zoom in that for me.
For you, I don't see it over there. But anyway, now let me see. Now once we have done this, if I'm able to share my screen, just give me 1 second. Let me see if I'm able to share because we did that privacy settings, right? On the desktop share. No, it's telling me the same thing.
Yeah, because I see over that in system settings, the screen and system audio recording. So screen and system audio recording, give permission to Google Chrome or give permission to whatever system you see over there.
Yeah, I gave permission to all. That's what I did initially only. Give me 1 second. Let me see. Where is Shweta? Just ask her. Give me 1 second. Shweta?
Hello everyone. So sorry. So we'll just take another 2 minutes.
No, she's not here. She just stepped out to walk her dog, I think, because I told her that everything was working.
Can you mail things to Sabha? Probably she can.
I'll mail it to Sabha. Yeah, maybe she can just pull it up and then I can just go over the slides right over here in the account. I'll just mail it to her. Sabha, can you just give me your Gmail? Can I just let me write it down so I can just email it?
I have your contact. I'll share it with you on WhatsApp.
Yeah, can you just share it with me, Sabha? I'll just email you the presentation.
I'll send you my email ID.
Oh, I just got it. Okay, good. Perfect. श्वेता, तेरा लैपटॉप मिलेगा क्या? It's not letting me security settings से allow नहीं कर रहा है वो. Yeah, if you don't mind, I'll just email you also the presentation. So in case. Yeah, I'm sending it to you also, Shweta. DRS Naran? No, yeah. DRS Naran. DRS Naran? DRS Naran. Yeah, I got it. Okay, Sabha, I sent it to you.
All right, just give me a moment here.
Yeah, it will take a little. मिल गया तेरे को?
In the meantime, you can start logging from her system as well.
She's just accessing her system, Sabha. She just got back. It's not letting me share my screen somehow. It's giving all the security settings.
So does this work? Questionnaires?
Yeah. You want to go ahead and let me see if Shweta is able to get it, then perfect. Otherwise, we'll do it from your screen also.
Yeah, sure. Perfect. So let's wait for another minute. Yeah. She'll be more comfortable if it's on her screen.
Yeah, not even that. It's just like easier, right? For me to just
true, for sure.
Go ahead, yeah. And then plus to run the mouse to show the findings, right? So it's.
I know. It's always better to be.
Yeah.
थोड़ा ये वो ऑफिशियल है ना थोड़ा सा डिले हो गया I think they check it also on system check.
Sorry, but maybe in the next few minutes we should be able to start.
Here.
Okay. Sure.
So do you want to attend? Do you want to send me that?
I'll give you the link to that, Shweta.
Yeah.
The webinar का link ना मैं तेरे को इसमें भेज रही हूँ. WhatsApp है इसमें? अच्छा तो मैं इसको भेजती हूँ तेरे को. Email भेजती हूँ इसका with the webinar information.
Yeah. Send it to DRS now. I'll open. Teams meeting है ना?
नहीं. Zoom है.
Zoom हाँ ठीक है Zoom open हो जाएगा. Teams सबसे अच्छा होता है actually.
बहुत सारे लोग Zoom ही यूज करते हैं आजकल। ये भेज दिया तेरे को वेबिनार इन्फॉर्मेशन।
अभी आपको नहीं आया तब तक मैं इसको Where did he send that webinar?
Yes, Narayan, the same one.
It's not here, I said.
Okay.
Let me forward it and myself first. Here.
Is it working, Dr. Shanaz?
Yeah. Just a minute. We're just logging into Zoom. She got the presentation. Just a few more minutes and we should be able to get on. आ गया? अच्छा. Or maybe we can start over here, Ankita, and by the time she logs on, then we can just switch over there also. Does that sound okay? Okay. Oh my God, I just hated that I'm late. Let me just tell people that I'm just trying to figure out this thing.
Sabha, you can introduce her in the meantime, yeah?
Yeah. All right, guys. I think we are being very thankful to the audience for being super patient on a Sunday. So I welcome you all. It is my absolute pleasure to introduce Dr. Shahnaz Elika. She's an accomplished pediatric neuroradiologist whose training spans NIMHANS Bangalore, Boston Children's Hospital, CHOP, as well as the Henry Ford Health System. And she's also ABR certified in neuroradiology. She is known for her clear, clinically grounded approach to complex brain and spine disorders. Today, she will be speaking on chiari 1 malformation. Please join me in warmly welcoming Dr. Elika.
Thank you, Sabha. I'm just trying to... Okay, Shweta? Okay, maybe Sabha, you can share the screen over here, and then when Shweta is ready, then I'll just switch over to that screen. Is that okay?
Sure. So I'm sharing my screen.
Okay.
And
you can just also forward. Can I move the mouse on your screen?
Yeah, I'm also handing you over the remote.
Okay, aa gaya. I'm just going to sign off and then I'll sign off the other one, okay?
Okay, all right. Yeah.
Okay, Shweta? Okay, I'll just leave this one.
मैं आपको पूरा वो रेडी करके देती हूँ. थोड़ा मुश्किल होगा आपको.
नहीं, कुछ नहीं. कैसे करना है?
Could you check they can see the slides?
Can you see the slides?
Yeah, great. Okay. I think we can start. Thank you all for being super patient, and also thank you for joining us on a Sunday.
Should I go shopping?
The camera is on now.
Okay, perfect. And then how do I make this screen? This is like this, right? Yeah. Perfect. Okay, everyone, sorry for this glitch. It's never happened before, but I guess the Apple computer always gives me trouble. Next time I should just carry my Galaxy Notepad also. Shweta, how do I make this small, like this camera thing? Can I just minimize that?
With this one.
Which one? This one?
Yeah, that's okay.
Okay, perfect. So actually, I'm not at University of Rochester anymore, but all this work was done there, and I have to acknowledge, one of my students. His name is James Ryan Loftus. Actually, he and I worked on this project, and we have a paper in radiographics on this. So this came out of that collaboration. So what I'm going to try to do, it's a short talk, so we'll get done fast. But what I'm going to try to talk about is basically tell you the nomenclature and the terminology of chiari 1 and its related deformities. So we're going to talk about chiari 0.5, 0.5, and 1.5. And I'm going to tell you why it's not a chiari 1 malformation and why it should be called a deformity. We'll talk about why that is. We'll describe the imaging evaluation of chiari 1 and its associated deformities, including conventional MRI as well as CSF flow studies. And then finally, we'll look at all the surgical techniques that are used to treat this condition. And we'll talk about some of the post-surgical appearances that you see. And we'll also look at some of the complications that you can encounter, which is not very often, but it's important to know. So why should we not call chiari 1 a malformation? So a malformation by definition is a fixed structural defect which is present at birth, and this occurs due to faulty embryonic or fetal during fetal life. And in this, chiari and its related subtypes are acquired, and this occurs after birth. And this occurs because there's a mismatch between the growth of the posterior fossa and the growth of the bone. So the bone does not match up to the development of the posterior fossa. That's when you get this chiari 1 deformity. And that's why we should not be calling it a malformation, because it's not present at birth, but you acquire it because of inadequate growth of the posterior cranial fossa relative to the hindbrain growth. And that's why what I'm trying to tell you in this whole presentation is, and in the paper also, is that it should not be called a malformation. It should be called a deformity. And this is also another reason why, because it can also go away. So you could have a chiari 1 deformity, and after a few years, the posterior fossa, the bone growth matches up to the hindbrain growth, and then the chiari deformity kind of abates. So that's the other reason why you should not call it a malformation, because otherwise it's a fixed thing, right? So here's an example of a patient who was scanned at 7 years of age. So this is the McRae line from the basion to the opistheon. You can see that the cerebellar tonsils were extending around 7 millimeters below the level of the foramen magnum. And there's also an elongated and peg-like tonsillar configuration. In addition to that, you can see that the caudal brainstem, normally the obex should be above the McRae's line. You can see the obex is below. And this is a follow-up at 18 years of age. And you can see that the tonsillar herniation has abated. The caudal brainstem descent is also is all gone away. So spontaneous resolution is possible. So many of these patients, you will see, actually, I do a lot of the PET scans, and I see a lot of them, 0.5. So we'll talk about what a 0.5 is, and then you'll see them on subsequent scan a few years later, it goes away. And the other opposite can also happen. Sometimes it can get worse. So many of these patients get follow-up. So we'll talk about what to see and what are the different kinds of studies you can do. So here are the different kinds of chiari subtypes. So we have the 0, which is cerebellar tonsillar herniation less than 5 millimeters below the level of the foramen magnum. And if you draw a line bisecting the medulla, the tonsils have a more ventral position. Then you have the type 1, where the tonsillar herniation is greater than 5 millimeters below the level of the foramen magnum. And then you have 1.5, where in addition to the tonsillar herniation, you also have herniation. You have what is called caudal brainstem descent, or the obex actually goes below the level of the foramen magnum or the McRae's line. And you see this kind of elongation of the medulla and fourth ventricle. So this fourth ventricle has almost like a little bit of a tubular appearance. Now these, like the 0 to 1.5, are all deformities. They're not malformations. And this occurs because of developmental failure of the paraxial mesoderm. Just like I told you, the bone does not match up to the hindbrain growth. So there's a bone-brain mismatch, and that's why this deformity occurs. Sorry, I'm also using the word malformation. And then you have your type 2, your chiari type 2 to 5, which are actually malformations. You're born with it. So the type 2 is when you have inferior cerebellar tonsillar ectopia along with a lumbar myelomeningocele. A type 3 is when you have an occipital or a cervical encephalocele rather than a myelomeningocele along with a chiari, like a posterior fossa, small posterior fossa with inferior cerebellar tonsillar herniation. And then you don't need to know the others, but what I was trying to get with this slide is that this from 0 to 1.5 basically are deformities, and then type 2 onwards to 5 basically are malformations. So let's look at a few examples of this. So chiari 0 or 0.5, it's interchangeable. Some people call it 0. 0.5 is when the tonsillar herniation is, I'll be repeating a lot of things just for, so it kind of, you remember it more when I keep repeating stuff. So tonsillar herniation less than 5 millimeters, caudal to the foramen magnum is 0 or 0.5. And then, like I said, the tonsils are positioned ventral to a line bisecting the medulla. That's very classic for this Chiari point, 0.5 or 0. And then you have the Chiari 1, where the tonsils go more than 5 millimeters below the level of the foramen magnum. And then you have the 1.5 with, in addition to that tonsillar herniation more than 5 millimeters, you also see descent of the obex. So some people also call it caudal brainstem descent. You could also say descent of the obex, or you could call it caudal brainstem descent. Either of those words are good. And then also remember that these Chiari deformities, these subtypes, are basically the pathophysiology is the same, so they likely represent a spectrum with increasing severity rather than distinct clinical entities. So I think it's basically just a spectrum of differing severities. They're not basically different. The pathophysiology is not different. The pathophysiology is just same. It's just like their severity is different. Okay, and all of these conditions, right from 0 to 0.5 to 1.5, can cause a syrinx. So don't be, you will be surprised to see, I'll show you examples where you have a Chiari 0 or a 0.5, and those patients also have a syrinx. So be mindful of that. It's not that the syrinx is only seen with the 1 or the 1.5, it can also be seen with the 0.5 or 0. Okay, and here's a graphic showing you, this is a normal patient. You can see the cerebellar tonsils as well as the obex are located above the foramen magnum. This is a 0 or a 0.5. You can see there is tonsillar herniation, but it is less than 5 millimeters, and these patients can have a syrinx. Then you have your type 1, where the tonsils are more than 5 millimeters, equal to of more than 5 millimeters, with or without a syrinx. And then you have the 1.5, where you have the caudal displacement of the brainstem or the obex, along with the cerebellar tonsillar herniation equal to or greater than 5 millimeters. And then, again, with or without a syrinx. Okay, so how do you image these patients? Basically, give me 1 second, let me just put this up here. There you go. So you can do morphologic imaging and you can do physiologic imaging, right? So morphologic imaging is basically your routine sequences. So you can do a sagittal T1, sagittal T2. You can do heavily T2-weighted sequences like CIS, Fiesta, SPACE. What the sagittal images show you, basically it assesses the degree of tonsillar herniation. Both the sagittal T1 and T2 will show you a syrinx, but obviously the T2 will show you the syrinx to better advantage. You can see on the CIS or Fiesta, you'll see more detailed assessment, or you can see more details of the tonsillar herniation. You can look for the craniocervical junction anomalies. You can see better the syrinx, as well as you can also see the nerve roots, the cervical spinal nerve roots. And in terms of physiologic assessment, basically you do two things. One is the phase contrast MR. You can do it in the axial or the sagittal planes. Most of the places where, in my last workplace, we just used it. We didn't do any kind of measurements. We just did it in the sagittal plane. But you can, what it's helpful for is to assess the alterations in the CSF dynamics that you see in these patients. And you can also obtain quantitative measurements. We never did that. And then you can do this cardiac gated cine true fast imaging with steady state precision, which basically is is good to assess tonsillar as well as cord motion. And I have videos and I'll show you examples of those as we go along. So what is the checklist? What all are we looking for in these patients with Chiari 1 deformity? So you want to look at the position of the tonsil. Obviously, how many millimeters is it below the Macrae line? We'll talk about what the Macrae line is. You look for the tonsillar shape. That's very important. Just like in the lymph nodes in the neck, we say that, morphology trumps size. Similarly, I'll also tell you here in the tonsils, I feel the morphology of the tonsils is again more important than the actual degree of how much below the foramen magnum it is. So if you have this kind of rounded configuration, I'll show you examples of that, versus this kind of elongated and peg-like appearance. Then you want to look for any kind of anomalies of the posterior cranial fossa or the craniocervical junction. So you want to look if there is a clival or supraoccipital hypoplasia. We'll talk about how this dissociation of the Macrae and Chamberlain's lines occurs. And then you want to look for the dens, the position of the dens. Is it retroflex? Some people call it retroverted, some people call it retroflex. It's the same thing. So you want to see how much of retroversion of the dens it is. And then you have certain measurements. We'll go over the measurements because that's important. And then you look for skull-base anomalies like platybasia. You look for vertebral segmentation like, atlanto-occipital assimilation or C2, C3 fusion. Then you also need to look for other signs like so there are other conditions, other diseases that can mimic a Chiari. So one example is craniosynostosis. You can have idiopathic intracranial hypotension. You can have spontaneous intracranial hypotension, intracranial hypertension, all of which can look like chiari 1 deformity. So you want to pay attention to all of that so that you're not calling those diseases as chiari 1 because the treatment is very different, right? So we'll go over how to, I'll show you some of those examples and we'll go over that, okay? So now let's look at the important lines and landmark. The most important line, which I want you to remember, is the Mecre line, which is a line which extends from the basion to the opistheon. And this is the most important line. And this is very important because I've seen people measure this very wrongly. Like most people will go very high up, like, they'll go here and they'll measure it. So it is actually tip of the basion to tip of the opistheon. Remember that, because then everyone's measurements differ then. So be very, be very diligent in how you measure it. So tip of the basion to the tip of the opistheon. And then the Chamberlain's line is from the hard palate to the opistheon. And normally these two lines should be following each other or they overlap each other. Should these two lines dissociate, and I'll show you an example, if those two lines diverge, that suggests that there is clival hypoplasia. And you can imagine if there is clival hypoplasia, your Mecre line will be a slightly higher up and your Chamberlain's line will be they will diverge. So that is actually an indirect indicator that there is clival hypoplasia. And then normally the dents should not extend more than 4 to 5 millimeters caudal to this Chamberlain's line, so that so there's no basilar invagination or you don't want that to happen. You always, that dents has to be at least 4 to 5 millimeters below that Mecre line. So this is an example of that divergence that I was talking about. So this is your Mecre's line, this is your Chamberlain's line. Normally they should be superimposed. If there is there is hypoplasia of the clivus, this line splits. Then you measure, you can also directly measure the clivus. There are measurements that people have done. So you can draw a line from the dorsum sella to the basion. So if it is, usually the clivus is small in patients with chiari 1, so around mean is around 34. Then you can also draw a line. There's a line that you can draw along tangent to the clivus. So along the posterior margin of the clivus, you can draw a line that is called the Wackenham's line. And how do you measure the supraocciput? The supraocciput is measured in the sagittal plane from the opistheon to the internal occipital protuberance. Again, in patients with chiari 1, this supraocciput can be hypoplastic. Again, the measurement is 38 millimeters around mean. And then you have the Twinning's line. This is the line which you extend from the dorsum sella to the internal occipital protuberance. Again, in patients with chiari 1, this can be shortened. Okay, so mean is around 81, so anything less than that. So here's the other important thing is how to measure. Like I said, there's a lot of, variance. Like when two people measure the chiari, it can be a little different. There's an inter-observer variability of approximately 2 millimeters. And historically, we measure the tonsils in the sagittal plane, right? But I would also tell you that sometimes, and especially be mindful that sometimes one tonsil is lower than the other. For example, you can have right greater than left. So always measure the side which is greater. And in that sense, I feel the coronal helps you a lot. Always corroborate your sagittal measurements with the coronal measurements. The coronals are a little bit, there's less inter-observer variability with that. So you see, so whenever you measure something in the sagittal plane, always kind of confirm those findings on the coronal plane. So that's what I usually do. If there one side is low, one tonsil is lower than the other, I always measure that tonsil which is lower, and then I always go back to the coronal plane and make sure what I measure in the sagittal plane is matching up with what I have on the coronal plane. I usually try to do that and measure it in 2 planes. So here's how you do it. So you draw this Mecre line from the basion to the opistheon, and then you draw perpendicular to that tip of the to the tonsil. And then I also went back on the coronal plane and I measured it, and I both come to around the same, and I know that that's what the right measurement is. So here's the basal angle. So the basal angle initially, this is from the nasion to the center of the sella, and then from there to the anterior border of the foramen magnum. So an angle more than 143 degrees is compatible with platybasia. Most of the times we use the modified basal angle. So basically you draw a line along the floor of the anterior cranial fossa to the dorsum sella. So you have actual bony landmarks, and from there to the basion, and that angle greater than 125 is compatible with platybasia. So you want to look for platybasia in these patients. Then you have, like I was talking to you about the degree of retroversion. So we do talk about a retroverted dens, but there's also quantification of that. So one of them is by doing this, by drawing this line. So this is, you draw a line along the inferior margin of C2, and then you draw another line along the tip of the odontoid on that, and you measure the angle between these two lines. So any angle less than 80 degrees is abnormal. And if you have an angle less than 70 degrees, those are associated, those patients have a higher rate of syrinx in these deformities. And there's another line which people draw, which is called the PBC2 line, which is also very popular. So what you do is you draw a line from the basion to the posterior-inferior margin of C2, and then from that line you draw perpendicular to the ventral dura. And that should be, if that is greater than 9 millimeters, those patients will also benefit. In addition to a posterior fossa decompression, those patients may also need transoral odontoid decompression, because that's more than 9 millimeters is considered abnormal. I think normal is around 6. So, and then finally, not many people talk about this, but this is an important one. This is called the clival canal angle. So what you do is you draw a line along the posterior margin of the clivus, which was called the Wackenheim's line, and then you draw another line along the posterior margin of the C2 vertebral body, and then where these two lines intersect is the angle that you get, which is called the clival canal angle. And if that is less than 150 degrees, so angle is less than 150 is considered abnormal, and if it is less than 135, that is more suggestive of craniocervical junction instability. So that's another thing that you can measure and pay attention. You'll see many of these chiari 1 patients will have this kind of narrow clival angle. Okay, so now coming to, we've looked at how this look, how to measure, what are the different angles, what are the different measurements of those angles, how do you measure retroflexion or retroversion of the dens, how do you measure platybasia. We've talked about that. Now let's come to the theory of how does the syringohydromyelia develop in these patients with chiari. So there are various theories. So the one that was very popular was the original one that was described by Gardner in 1958. So he talks about what happens is that these arterial pulsations are transferred to CSF, and this so what happens is that he thought that with this constant piston-like motion of this tonsil, the CSF is driven from the fourth ventricle into the central canal by this tonsillar obstruction. But there are various pathological and imaging studies have failed to consistently demonstrate this phenomenon. So then the other theory is that it may be coming from the subarachnoid space. So when you have obstruction of CSF at the foramen magnum because of this piston-like movement of the cerebellar tonsils during systole and during systole, that can drive CSF from the subarachnoid space into the central canal via the perivascular spaces. And we see this. This is, I think, an inferred mechanism, and you see it many a times. You'll do a myelogram, and then if the patient has a syrinx, you'll see that the contrast will actually come into the syrinx. So some people speculate that this is the cause of it. And then finally, it could also be because of extracellular fluid coming into the central canal. That is because of decreased compliance of the subarachnoid space and spinal veins from the tonsillar blockade. And there's loss of this normal CSF circulation. And this explains how, partly this explains how sometimes, I don't know if you've seen patients with pre-syrinx state, meaning there is no syrinx, but there's this ill-defined T2 hyperintensity, and then as you follow them up, they will actually progress to form a syrinx. So this extracellular fluid hypothesis explains how you go from pre-syrinx state to syrinx. But in reality, I feel maybe there's a combination of factors that occurs, and like I said, no one hypothesis is universally accepted currently. Okay, so let's look at what exactly happens during systole and diastole in these patients with chiari 1 deformity. So this is normal systole. What happens is that your CSF goes down the foramen magnum, and during diastole, CSF comes up. Now, in these patients with chiari 1 and related deformities, what happens is that when you have this kind of ectopia, the cerebellar tonsils kind of have this kind of piston-like motion, and this generates cervical subarachnoid pressure waves, and those pressure waves tend to compress the cord from inside out, driving the CSF from the spinal subarachnoid space through the perivascular spaces into the central canal. And then when you actually do a posterior fossa decompression, you basically take out those effects, and then the CSF improves. So this lower figure actually shows you that once you do a posterior fossa decompression with or without duroplasty, you basically take out that piston-like action of the cerebellar tonsils. Those pressure waves that are generated in the cervical subarachnoid space kind of reduce, and that's the reason why the syrinx goes away. And this is just an axial graphic showing you the same thing. So here what you can see is that there are these pressure waves. So you see this? So these pressure waves are generated in the cervical subarachnoid space, which push the cord from outside in. And then this drives the CSF to come in through these perivascular spaces towards the central canal and form a syrinx. Okay. Okay, now let's talk about the physiologic assessment of chiari 1. So this is the phase contrast imaging is the mainstay for physiologic assessment of CSF flow, abnormal CSF flow dynamics in these patients with chiari 1. It gives you both qualitative and quantitative data. You can evaluate abnormal tonsillar as well as spinal cord motion. And then I will show you what are the different kinds of qualitative. I look more at the qualitative flow abnormalities and I'll show you how I do it. We use the FAN classification. And I'll show you examples of these as I go along. So here's just for people who are just starting, this is just to tell you how you should read CSF flow study. So when you do a CSF flow study, you get these three kind of images. This is called a rephased image. This is flow compensated. And how do you know this is a rephased image? The flow will be hyperintense and the background will be visible. And this is useful for assessing tonsillar as well as spinal cord motion. Then you have a magnitude image. This shows you the magnitude of phase shift without directionality. So this gives you what is the magnitude of phase shift, but it doesn't show you any direction of flow. And how do you identify this magnitude image? You will see that the background, the static background, the background which is not moving will be hypointense and the flow will be hyperintense. And then you have the phase image, which demonstrates both the magnitude as well as the direction of the phase shift. And by arbitrary convention, stationary background is mid-gray, as you can see over here. Caudal flow is hypointense and cranial flow is hyperintense. So just remember that convention, but obviously it depends on whether your scanner is right or left-handed. But by convention, this is what we see. So let's look at the different types of impedance to CSF flow. So this is a normal patient. You can see CSF flow along the dorsal aspect of the foramen magnum. This black. You can see CSF flow along the ventral aspect of the foramen magnum, and you can also see CSF flow in the fourth ventricle. So this is a normal subtype. Now let's look at what a fan type 1 looks like. Here you can see, if you go back, you see this black stuff here at the back you're missing that on the next one. You see that? So you're not seeing flow dorsal to the foramen magnum. You're seeing some flow in the fourth ventricle, and you're also seeing flow ventral along the ventral subarachnoid spaces along the foramen magnum. So this is a fan type 1. Then coming to fan type 2, let's see. You're not seeing flow in the dorsal portion of the foramen magnum. You're not seeing flow in the fourth ventricle, but you're seeing preserved flow in the ventral aspect of the foramen magnum. So this is a fan type 2. And then you have a fan type 3 where you're seeing a very, restricted flow dorsally, restricted flow in the fourth ventricle, and also restricted flow along the ventral aspect of the foramen magnum. This is a type 3 pattern. So these are all qualitative ways to look at the CSF flow, and that's what we routinely do in clinical practice. And the additional findings that you're going to see, this is another finding that you should talk about. This is called synchronous bidirectional flow. Normally, when you see flow, it should be either black or white, right? So here you're seeing over here, there's turbulent flow. So you're seeing, it's almost like aliasing. So you're seeing black and white, right? So this is called synchronous bidirectional flow. This is because of turbulent flow and that causes aliasing. And in this patient, you can also see there is restricted flow along the dorsal aspect as well as the fourth ventricle. And this is that cine clip that I was telling you that we do these cines where we do this basically steady state gradient echo sequences. You can see the abnormal tonsillar as well as the brainstem motion. And in this patient, you can see that the tonsils are elongated peg-like. You can see the dorsal, the caudal brainstem descent or the descent of the obex. So these are also things that we do. We do them on all chiari patients. So this is also something that you can do. Okay, so also remember that when you have these phase contrast images, there can be certain pitfalls. So one is you can have aliasing related to the basilar artery, which can cause this kind of black and white in the prepontine cistern. So be mindful of that. But you see this is like rounded and it is corresponding to the basilar artery. So you just want to make sure that you're not calling that as synchronous bidirectional flow. You can see otherwise it's all black, right? It's just where the basilar artery is, you're seeing a little bit of aliasing. And then because this is phase contrast imaging, if you have your VENC or the velocity encoding gradient set to very high, you may not see any CSF flow and you may call this abnormal, right? And once you correct the VENC, you see that, the CSF flow is normal. And obviously, you're not going to read any of these phase contrast studies in isolation. You're always going to look at your T2 weighted images and your other morphologic imaging studies. So here you can see that, the posterior fossa is stone cold normal. It's just that the VENC was set too high. You're not seeing the flow. So be mindful of that. And then if you don't have phase contrast, there are a lot of the conventional morphologic images can also tell you that, or they can be clues to abnormal CSF flow dynamics. So here's a patient who has, this, and we see this all the time, right? When you have this signal void from dephasing. There's abnormal tonsillar motion that causes a signal void. So you could use the FLAIR images to suggest that there might be abnormal motion of the tonsils and hyperdynamic CSF flow. So this is a combination of that's causing it. You can see this kind of jet of CSF from, because their ventral subarachnoid space is narrowed. So you could use that. So the CSF jet or the T2, hypointense signal in the CSF. And then you can have this kind of ghosting artifacts from CSF pulsations too. So if you don't have phase contrast, you can also use your conventional imaging to advantage. And then now we've learned all this, the qualitative evaluation of phase contrast imaging. We looked at how it, chiari 1 deformity looks in morphologic imaging. So now let's start putting it all together. So here's an example of a patient. So coming in with headache. So here you can see that the McRae line here, you can see that the tonsils are extending less than 5 millimeters below the level of the foramen magnum. You can see there's dissociation of the McRae and Chamberlain's lines, suggesting that there is some clival hypoplasia, which you can also see on, even if you look at the clivus, it looks a little bit shortened. And then you'll see there's a little bit of crowding at the posterior fossa syrinx, posterior fossa subarachnoid spaces. And you can see here, even though the degree of tonsillar herniation is not that much, you can see that this patient has already developed a syrinx. So this is a chiari 0 or a 0.5. Then when we go to the phase contrast imaging, you can see that there is restricted CSF flow in the dorsal aspect of the foramen magnum and the fourth ventricle, but there's preserved flow along the ventral foramen magnum. And in this patient on the sagittal T2, you can see the degree of syrinx. And you can see here that the tonsils are mildly rounded, but they're not greater than 5 millimeters. So that's why it is a 0.0 or a 0.5. Now coming to how does a chiari 1 look? So here's a patient, there is inferior cerebellar tonsillar herniation greater than 5 millimeters. The tonsils have this kind of elongated and peg-like tonsillar configuration. When we do the flow studies, you can see that there is restricted flow along the dorsal foramen magnum and in the fourth ventricle, but the ventral CSF flow is preserved. And on your T2 weighted images, you can see the tonsillar herniation along with that kind of elongated and peg-like appearance and the syrinx in the cervicothoracic cord. Now coming to 1.5. So in this patient, you're seeing that there is tonsillar herniation greater than 5 millimeters. You can see that the obex should have been above the McRae's line. The obex is down here. And then you can see this long segment hostrated syrinx in the cervicothoracic cord. And then when you do the CSF flow studies, you can see that there is impedance of CSF flow dorsally, ventrally, and in the fourth ventricle. And so, many of you may ask that why is it important to know the difference between 0.5 or 0 and 1 and 1.5? It's important to identify 1.5 because this subtype has higher rates of syrinx postoperatively, and also they are going to be more symptomatic than patients who are 0 or 0/0.5 or 1, and they may require more involved decompression, meaning that they might not just require posterior fossa decompression, they may require, in addition to that, a duroplasty or a tonsillopexy or something like that, in addition to just a conventional posterior fossa decompression. Okay, now, so this is another patient, again, showing you the inferior cerebellar tonsillar herniation. You can see the elongated and peg-like tonsillar configuration. You can see this patient has the syrinx. They also have C2-C3 fusion. They also have a scoliosis. And the CSF flow studies show that there is impedance of CSF flow ventrally. There is this kind of synchronous bidirectional or turbulent flow ventrally, and you can also see, lack of flow in the fourth ventricle. And this is after the posterior fossa decompression. You can see that there is some, there's improved crowding at the of the posterior cranial fossa. There's resolution of the syrinx. Obviously, the C2-C3 fusion will persist, so that's still seen. Let's not talk about chiari 2. I don't want to talk about that today. Okay, now coming to who should get a foramen magnum decom. I'm not a surgeon, but just generally to know, because we see so many of these patients, just to know how clinicians manage or surgeons manage these patients. So classic, they say that chiari 1 is a great mimicker, right? They can present with different kinds of manifestations. They can present with sleep apnea. They can have posterior headaches. So classically, they talked about Valsalva induced headaches, right? They can have posterior headaches, neck pain. You can have symptoms related to syrinx. So you can have paresthesias and loss of pain and temperature sensation in the upper extremities, discoordination, like we said, dysphagia, dysphonia, sleep apnea, many other things. So in terms of management, you'll see all these chiari. Like I said, I see maybe a 0 or a 0.5 routinely if I'm reading 30 studies in a say, I might see it in 1 or 2 kids. But if they're asymptomatic, they just follow them up. If they have headaches, 50% of neurosurgeons will intervene if they're bad headaches or if they have those Valsalva kind of headaches, right? If they have progressive syringohydromyelia, usually they will operate. If they have, most of the times when they have scoliosis, it's related to syringohydromyelia. If they have scoliosis in the absence of syringohydromyelia, that is uncommon presentation, but surgery is usually recommended in those patients. So now, like I said, when you see chiari 1 and its related deformities, always make sure that you're not calling, it's not some other disease entity like idiopathic intracranial hypertension or spontaneous intracranial hypotension or craniosynostosis, which are kind of one of the causes of the tonsillar herniation. Because of, one is, I'll show you examples. So just to show you, so this is a patient who has idiopathic intracranial hypertension. You can see the mild inferior tonsillar herniation, but the posterior fossa is normal. You can see that abnormal hypointensity in the cerebellar tonsils from abnormal motion. This patient also had papilledema, and if you on the MRV, they had this narrowing of the lateral aspects of their transverse sinuses. So this is a patient with IIH. So this is treatment is completely different, right? You basically treat it as IIH. You don't want to do a posterior fossa decompression in these patients. Now coming to intracranial hypotension, this can also mimic. I've seen various examples of this disease being called a chiari 1. So here, this is how you differentiate, spontaneous intracranial hypotension from chiari 1. So you will see that there is in this patient also there is herniation of the cerebellar tonsils. You can see that there is brainstem stag. You can see that the third ventricle is kind of low lying. You can see the superior convexity of the pituitary gland. You can see the engorged dural venous sinuses, right? And then this patient also had a syrinx. And then once they did a blood patch on this patient, you can see that the chiari or the inferior tonsillar herniation has improved and the syrinx has also improved. So in this patient, doing a posterior fossa decompression would not have been the best treatment. So just don't look at you have to put the whole picture together. Just don't look at just don't look and see that, oh, there is herniation, this is chiari 1 deformity. No, it could be IIH, it could be spontaneous intracranial hypertension. So be mindful of those disease entities also, and make sure you look at your history and all the other imaging findings before you make a diagnosis. This is another patient with craniosynostosis. Again, in craniosynostosis, the sutures are fused, so there's no space to grow, so the tonsils kind of pooch down. So here's an example of such a patient. So you can see the tonsils going down, a lot of hyperdynamic CSF flow at the foramen magnum. So just like I said, be mindful of this disease entity also. And obviously this is very obvious, right? So if you have a posterior fossa mass, that can cause tonsillar herniation. We are not going to call that, but I just added in there just to kind of complete the picture. Okay, now coming to surgical techniques. So the classic one is the foramen magnum or posterior fossa decompression. So you do what is called a suboccipital craniectomy and C1 laminectomy. This shows you the graphics. So you take out this bone as well as the C1 lamina. And then in addition to that, you can do add-ons, like, how you buy a bowl, you can add things on. So it's that. So it can be with duroplasty. In duroplasty, what they do is they open up the dura. So that's like more advanced surgery. So they open up the dura. So they'll open it up like maybe horizontally and sew it vertically so that there's more space, so the dura is also kind of widened out. So you can have that with duroplasty. You can have it with duroplasty and arachnoidolysis. So what you do is they open up the dura. Sometimes there are arachnoid adhesions near the tonsils. They go and lyse those adhesions. And then you can have one where they do what is called the tonsillopexy, meaning they cauterize the tonsils. So what happens is that the tonsils kind of retract up, and the imaging looks much better post-surgically. But you can have complications from that, and I'll show you a few examples of that. And then you can have, like we described, when your PBC2 line is very like more than 9, you can have this severe ventral compression from that odontoid retroflexion. So those patients may require, transoral odontoid decompression. And then if these patients have hydrocephalus, you can do you can do shunting, endoscopic third ventriculostomy. If the syrinx is there, you can do a syringo-subarachnoid shunting. So there are various, other things you can do. So here's an example. So now once you have the surgical, when you have post-surgical scans, I see a lot of patients still saying tonsillar ectopia, herniation. No, there is a specific language or verbiage that you have to use in the post-operative imaging of these patients. So we don't call it the foramen magnum anymore once they've done surgery. We call it neo-foramen magnum. So we measured it from the basion to the new margin, or whatever the suboccipital craniectomy where it ends, that will be your new basion. So we don't call it foramen magnum anymore. We call it neo-foramen magnum. And then we don't call it cerebellar tonsillar herniation after surgery. We call it cerebellar tonsillar ptosis or slump. And you know how, like I said, normally we measure it from the basion to the neo-opistheon, but then, Duddy proposed this alternative measurement, and I'll show you because what happens. So this is a line, you draw a line from the Chamberlain's line to so you can draw a line along which is perpendicular to the hard palate, to the anterior arch of C1 and to the, what were they going to say? So tangent to the hard palate and anterior arch of C1, you draw a straight line, and then you draw a perpendicular to the vestigium, which is this pointy structure of the fourth ventricle. So if there's a decrease in this distance, that suggests that there is increasing cerebellar tonsillar slump. So we call it slump or cerebellar ptosis. We don't call it herniation after surgery. And then after tonsillopexy, like I said, you cauterize the tonsils. So, when you do the post-op scans, the scans look much better. So, but sometimes you can see this. In this case, it's very subtle. The surgeon is obviously very good, but you can see there's a little bit of encephalomalacia. I've seen worse cases, but you can see that there's a little bit of encephalomalacia and gliosis because they cauterize the left tonsil. So, just to look for those things, like little things, you'll start seeing them when you pay attention. Otherwise, when you routinely read this, you don't look for these subtle things, but when you know what to look for, you'll start seeing much more. Okay, now coming to how do I put everything together, the post-operative imaging? So here's a patient. This is the pre-op imaging. I can see cerebellar tonsillar herniation greater than 5 millimeters below the Mecre line, a hostrated syrinx. CSF flow studies show impedance along the dorsal aspect of the foramen magnum with preserved ventral flow. This is after surgery. The other thing is, they don't talk about it much, but this is what my experience I have seen. This is the decompression. When you see this kind of concave appearance, you see how the posterior fossa bone looks like. When you see this appearance, like, this bulging of the CSF space posteriorly like that, this bulge, usually that suggests that they've had a duroplasty. So even if I don't look at the clinical notes or the surgical notes, I know this patient has a duroplasty because it's kind of got this kind of bulging appearance of that posterior fossa. That's very classic for a duroplasty. So, and you can see here the tonsillar, you don't see much slump anymore. The tonsils don't look elongated and peg-like like they did. And you can see the posterior fossa crowding has substantially improved. The syrinx has reduced in size. And when I do the CSF flow study, I can see there's improved CSF flow dorsally. And there was ventrally there was already good flow, but you can see that how the CSF flows has improved along the dorsal aspect postoperatively. And again, just another patient showing you, this is actually one of those balanced steady states in AMRIs. You can see the abnormal tonsillar and cord motion. And here you can see that after surgery, there is more normalization of the tonsillar and cord motion, and the syrinx has reduced in size. Now coming to transoral how does imaging look after you do a transoral odontoid decompression? Again, like I said, this is not something that you see very commonly, but just to know how it looks. So here's a patient who had tonsillar herniation. The patient also had platybasia. They also had this odontoid retroversion. And this patient underwent both the posterior fossa decompression as well as transoral odontoid resection. And you can see that and they've also done a fusion, right? They've done an occipitocervical fusion in this patient. And then post-operatively, you can see that there is robust CSF flow both ventrally as well as dorsally, suggesting that there is a good, successful or good decompression. So what are the different complications? Obviously, there are multiple complications. Some of it, these are all routine, post-surgical stuff, but I'll show you some of the complications that we see imaging-wise. So here's a patient. So one of them is these arachnoid adhesions that can form. So here's a patient who had a suboccipital craniectomy, C1 laminectomy, and duroplasty. Here you can see there is this adhesion, and there is some residual cerebellar tonsillar ptosis and slump. And you can see this patient also has a little bit of retroflexion of the dens. This is another patient. Again, this patient also had, an arachnoid adhesion. And you can see this patient had a persistent syrinx. The syrinx didn't go away. So when they went back the second look, they took out this adhesion. And now you can see, so let's look at I'll show you the scan. So this is the post-operative phase contrast MRI, and then I'll show you the second surgery look. So here you can see that there is impedance of flow dorsally adjacent to that arachnoid adhesion, and a little bit of impedance of flow ventrally. And then this is after they did that second arachnoidolysis. You can see that they took out that addition. Now you can see that there is improved CSF flow at the, along the dorsal aspect. So let me go back. So see this, let me remove my arrow and see that there's improved flow. So then obviously the other surgical complications, pseudomeningocele, we see them, so I'm not going to spend too much time over there. So you know how a pseudomeningocele looks. So now talking about how you can sometimes get what is called exuberant cerebellar ptosis or slump. It's also called the slump syndrome. So here's a patient, 5-year-old, initial preoperative MRI. There is inferior cerebellar tonsillar herniation. There is impedance of CSF flow both dorsally and ventrally. This is the first post-op scan. You can see they've done a suboccipital craniectomy, C1 laminectomy, and duroplasty. There is adequate decompression of the posterior fossa. You can see that there is a little bit of tonsillar slump. Do you see that? The tonsils are still lower than that from the basion to the neo-opistheon. They still are below that line, so there is slump. And you can see over here from the pre-op to the post-op, there is improved CSF flow both along the ventral and dorsal aspects of the neoforamen magnum. So good results. Now this patient comes back a year later, but they have recurrent symptoms that they had before surgery. So now if you look at the second post-op, second scan, you can see now there is increasing cerebellar slump. So let me go back so you can see. So from there to here, do you see that? Now there's more crowding at that neoforamen magnum. Do you see that? And now when you look at the second post-operative phase contrast MR, now there's restriction of CSF flow, both ventrally as well as dorsally. This is the neoforamen magnum. And now this is after this repeat duroplasty and they did a tonsillopexy. You can see there's improved tonsillar ptosis relative to that neoforamen magnum, and there is also improved CSF flow along the ventral and dorsal aspects of the neoforamen magnum. So pay attention to the exuberant cerebellar ptosis or slump syndrome. Okay, so now just showing you a management algorithm or example management algorithm for chiari 1. So if you see tonsillar herniation, first you want to make sure patients don't have IIH, SIH, craniosynostosis, etc. So if they have that, then you treat the underlying cause, right? If the tonsillar herniation is not related to this, then it's attributable to chiari 1 or its related deformities. Then you want to see if they have if they are not symptomatic and it's an incidental radiologic finding. If they have no syrinx and they're asymptomatic, they just undergo clinical follow-up. If they have a syrinx, they have clinical as well as MRI follow-up. If they are symptomatic with or without a syrinx, if it's minor symptoms, minor scoliosis, atypical headaches, you just get clinical and MRI follow-up. If they have major symptoms like Valsalva-related headaches or respiratory disturbances or symptoms of syringohydromyelia, then you do a standard posterior fossa decompression or a foramen magnum decompression, suboccipital decompression, C1 laminectomy, and plus or minus duroplasty. Some of these patients with chiari 1 can have a hydrocephalus, so you can do ETV or shunting. If their symptoms persist, then you can go ahead and do a foramen magnum decompression. If they have craniocervical anomalies, then you look for whether they have instability on dynamic CT or MR. And if they're not unstable, then you just do regular foramen magnum decompression. If they have instability, then you do FMD along with craniocervical fixation. So to summarize, don't call it a malformation. Like I said, the chiari, 0/0.51 and 1.5 are developmental anomalies, and they're associated with other derangements of the craniocervical junction. So just don't measure the tonsillar herniation. Look for other anomalies like we discussed, the skull-base deformities, the craniocervical junction anomalies. And then also, like we have discussed in this, you should look at the morphologic as well as the physiologic assessment. And many a times just the qualitative assessment will help you a ton in making, in saying a lot of things like, the flow at the dorsal and ventral aspects of the foramen magnum. And then knowing how the imaging looks before and after surgery, that's very important. And then using the right verbiage, like I discussed, right? What are the different terminologies you use after surgery? And then we talked about the different surgical techniques that are used in these patients and what are their potential advantages and what are their complications. So we discussed all of this. So those are my references. So that's it.